Good afternoon. This is Bill Kose here at Blanchard Valley Health System. Welcome to our Live and Learn. We're going to talk today about obstetrics and gynecology. A couple reminders before we do get started. Remember to send in questions. Email them to us. We'll try to get to all of them. If not, we will get back with you with email. Also, you will be getting a survey. We really appreciate you filling that out. That gives us an idea of are we on the right topic. But in addition to that, if you have any suggestions that you'd like to hear from us, please note those and send them in. I'm going to turn this over to Allison for introductions today. Again, we're talking about obstetrics and gynecology, and we look forward to your questions. So Allison, it's all yours.
Thanks, Dr. Kose, for having us here today. I'm Dr. Westcott, for those of you who don't know me. I'm an OBGYN, a delivering doc, and I've been in the Findlay area for a little over 8 years. I'm a mom of 2 little girls, and I think the best part of my job is developing a relationship with my patients, getting to deliver their babies, and then seeing them grow up as healthy kids.
Hi, and thank you. I very much appreciate you inviting me to talk today. My name is Sarah Weihrauch, and I'm a physician assistant. I've been a physician assistant I'm in my 19th year now. All of those years right here in Findlay, Ohio, all of those years in women's health and OBGYN. I agree, very, very proud to be part of this community and work here in women's health as a physician assistant, basically a medical provider that can do about 80% of what a physician does. We're trained, typically a master's degree. We're able to see patients and evaluate them in office, order labs, interpret labs, prescribe, and I can assist in surgery. So that's kind of what a physician assistant does. So,
what's your favorite part about women's health?
I just love building relationships.
Mm-hmm.
I like having that patient who can trust me and come in and just kind of seeing them through things that might be difficult, but also helping them through preventative visits and things that way. So
yeah.
And in your world, why would you choose OBGYN? That's why we're here today. So I'll let you start that.
Yeah. So first I want to say that the OBGYN office is not a scary place. People avoid us quite a bit because they're not sure what's going to happen there. You don't necessarily need a pap smear every single time you come in. We see women and we take care of women through all stages of life, through all ages of life, and provide a wide array of services. Even adolescents who are maybe coming in because of pubertal issues or problem periods, or maybe they need birth control. This is not old school OBGYN where you need a PAP at your first visit. We only do PAPs after the age of 21.
Yeah. So like our slogan reads, care throughout a woman's life span. Initially, we like to make sure that women are coming in for their annual wellness or annual routine visits. Yeah. And even though you don't need a pap test, the guidelines for your cervical cancer screen or pap test have changed. It is important that you are seen yearly so that we can update medical history. And again, it's about building that relationship so that if you're coming in for your routine visits when you're not necessarily having problems, then if certain problems present, you'll be more likely to have them taken care of. Mm-hmm. Because we do a lot. In our office, we're treating irregular menstrual periods, pelvic pain, talking about birth control options. We offer many different types, implantable, oral, mm-hmm. Permanent sterilization if they need.
You do a lot of urodynamics too.
Yep. Urodynamics is a bladder test, like kind of almost an EKG for the bladder. So helping women through some of those things, pelvic organ prolapse, urinary incontinence, fertility issues, polycystic ovarian syndrome.
I was going to say, we see a lot of people with PCOS, people who are trying to lose weight before they have a baby. And we do a lot of in-office procedures too. Yep. Birth control is the thing in the arm, and the IUDs that you mentioned. And
endometriosis, mm-hmm. and obviously you, OB care. I mean,
yeah, we do a lot of high-risk OB care as well.
Yeah,
we do a lot of infertility, maybe not quite IVF, but we do a lot of infertility, but we take care of IVF pregnancies.
And you're saying we, I guess we should talk about we meaning Blanchard Valley OBGYN. So we include a great group of physicians, physician assistants, nurse practitioners, nurse midwives, nurses, MAs, secretarial staff, all of that to include us. And we work kind of in a care team model. A care team model is interesting because it will include one supervising physician have one mid-level provider, such as a nurse practitioner, physician assistant, nurse midwife. Then that care team also will include a nurse, medical assistant, and a secretarial staff. And so usually our care teams consist of 5 people, and that kind of makes it so that the patient kind of has that
point of contact person. So when they're calling a big office, hey, I'm a patient of Dr. Westcott, can I talk to Beth? They can put a voice with a name, and they're getting that same person, that same consistent care each time. And that makes a difference because our staff knows our patients really well.
Exactly. And as for me, as for a physician assistant, I think it really helps, that having a great supervising physician. Obviously, Dr. Lori Thomas Schultz is my main supervising physician, but I also collaborate with the other docs as well. But having that relationship is so important, and all the physicians here are very approachable, very knowledgeable, and it's just great minds and having someone to bounce something off. But it also ultimately what it does is provide the best care for our patients.
Mm-hmm.
So
we have a few different locations. We're here in Findlay, we're in Bluffton, we have an office in Cary, we're in Ottawa, hoping to get back out to Fostoria soon.
Yeah, and that's what's great for patients. You can have your care in any of those locations, or Findlay. And so it's a great opportunity. I think it helps. And we have a very experienced staff. I think anywhere from some of our providers, 20,
almost
30 years.
Mm-hmm. Yeah.
So there's a lot of experience here. And to further that, even experience in the hospital setting. Mm-hmm. So our OB department, labor and delivery nurses, my oldest baby is now 17, so not a baby anymore, but I had all 3 of my children here at Blanchard Valley OBGYN, at Blanchard Valley Health System, and had a great experience. And some of those labor and delivery nurses still up on the floor.
Still there. Yep.
Still providing great care, and certainly the abundance of their experience, they've really shaped that department into being really quite wonderful, I think. So
another thing I really like about our practice is that we keep striving to improve patient access to care. So we now have some mid-levels who see males for STD testing and treatment. We have some expanded office hours, 7 a.m. to 7 p.m., some providers at some locations, just to try to help accommodate those weird work schedules. We are hooked up with a patient portal, so you can see your lab results, your Pap test results online, instead of waiting for a letter or a phone call from the office. Mm-hmm. We now also do text reminders for your appointment visit, because it's way more convenient than a phone call.
Telehealth visits, during COVID, we've kind of opened up that route, which has been more, safer in some cases and has worked really well. Social workers that we have here, dietitians that we can, all right in our location, all right in our area. It's just a great option for patients.
And it's usually everything's kind of just together right there in the one office. We have labs and ultrasounds available usually in each location where we see patients for the most part.
And that, another thing about, improving access to care, I think one of our benefits is the relationships that we have with other specialties, gastrointestinal, urology, hematology, cancer care. These are relationships that we have with those providers, the general surgeons in town, certainly. It's really nice to have that, and again gives the patient better care. Even if it's not an OBGYN problem that we can help you with, maybe we can get you referred, and we know someone to get you to that would help you through it. So, and the other thing we wanted to talk about is, so why do we want to deliver? Why do we want to have our babies in Findlay or Bluffton? And I'll let you kind of kick over from there.
And that's one of the bigger questions I get is, what's the difference between Findlay and Bluffton? How do I know which place to go? They are both really great facilities. They are both obviously able to deliver babies. There are private rooms with private bathrooms in both one. They both still allow your support person. The ability to do a C-section is available both places. We have experienced labor and delivery nurses both places. We have a pediatric hospitalist, lactation consultants. The biggest difference, number one, in Bluffton, you do still get milkshakes. So that's Yeah, that's awesome.
Yeah.
But the biggest difference is really the acuity level. So Bluffton is awesome for lower risk deliveries that are close to term. So their nursery is able to take care of babies that are 36 weeks and up, and it has to be a pretty low risk pregnancy. Finley's a little different. We can still take care of those patients, but there's a higher acuity level. So I'll say that we have a level 2 NICU, which means neonatal intensive care unit. So we are able to care for babies 32 weeks and up, which is 2 months before the due date. We're also able to care for a wide range of high risk diagnoses there.
Yeah, high risk OB, that includes a lot of things that we help with. So
that's a lot. So high risk diagnoses would be gestational diabetes or any diabetes in pregnancy, high blood pressures in pregnancy, preeclampsia, preterm labor, IVF pregnancies, multiples or twins specifically, elderly pregnancies, which I can say because I'm old. And so we actually have, we take that very seriously, and we try to keep as many patients here and not send them to a tertiary care facility unless it's absolutely needed. So we have a meeting where we review all of the chart and the information for all of our high risk obstetrical patients to ensure that they're getting the best plan of care. Our main goal is healthy moms, healthy babies.
And that's great. And by we, she means all the supervising physicians of the staff, all the mid-level providers, the nurse practitioners, and the physician assistants, and the midwives, and the nurses, and the MAs, all come together on that meeting, which is such a learning too for them, but it helps us all be on the same page and just, again, offer the best care for our patients. So.
Little shout out to my ultrasound ladies while we're talking about high risk OBGYN. Yeah. All of our ladies in our offices who do the ultrasounds are phenomenal. They are all excellently trained. They are very thorough and really care about the detail that they give. Yeah. And they not only are they already good, but they're striving and continuing to learn new techniques to try to pick up other small birth defects that would be important to pick up ahead of time.
Yeah.
So,
and if you're giving them a shout out for OB, I'll do the same about giving the ultrasound techs a shout out for GYN. They are helping us identify the patients who are having pelvic pain or endometriosis. Maybe they have ovarian cyst or uterine fibroids. Maybe they are considering surgery and we need to have an ultrasound to for surgery planning. Maybe a woman is going through fertility issues and needs ultrasound for fertility scans to look at follicles. Our ultrasound techs do all of it, and they've got years of experience, and they certainly help us out in that avenue. So
I don't think we could really do our jobs as well as what we do if we didn't have them.
Yep.
So
great. So, and I guess
one of the other hot topics that I figured was going to come as a question is about the HPV or human papillomavirus. What is it? What is with the vaccine? Should I be getting it? So HPV, human papillomavirus, causes cervical cancer. We are really good at papping people for it. So the rates of cervical cancer are actually slowly declining because you're going to go to pap jail if you don't get a pap. I'm just kidding. But HPV also causes anal cancer in guys and girls, penis cancer, and a really bad head and neck cancer in guys. And, it's easy to pap someone and look for HPV that way. But guys don't go to the dentist and get a mouth pap. That's just not a thing. So all those other cancers are on the rise. Yeah. Last summer 2019, the CDC, Centers for Disease, and I think we all know that by now because of COVID, we've all looked that website up. But CDC.gov, they came out last summer and said, instead of offering the HPV vaccine, the Gardasil shots, to ladies and men younger than the age of 26, let's increase the age up to age 45 to see if we can help knock out some of these other cancers. So if you were never offered the HPV vaccine and you were age 45 or younger, you are back in the group. It's 3 shots over a period of about 6 months to a year. Insurances are doing a way better job of covering it, even for us older people, but it does help prevent high-risk HPV and
very good
abnormal paps.
Yeah. And then one other thing, I wanted to talk a little bit about our surgery department, because that's one thing that we we have really good at Blanchard Valley OBGYN. It obviously starts with the surgeons. We have plenty of trained surgeons who do really amazing things. We have minimally invasive surgery, robotic surgery. And, for a hospital this size, we have 3 robots in Findlay, 1 in Bluffton, and that you just don't see every day.
Yeah,
And
hospitals our size don't generally even have a robot.
and we've had them for years. And so a lot of trained surgeons that are doing these minimally invasive surgeries, things like hysterectomies, laparoscopic surgeries, tubal ligation, but also the more skilled, deep infiltrating endometriosis resection, large uterine fibroids. So we're talking fibroids the size of a watermelon being pulled out of after a woman just has 4 small 8-millimeter incisions. So that kind of thing, very awesome. One procedure in particular, the laparoscopic birch, is a procedure Dr. Lori Thomas and Dr. Jordan both do. And that procedure is for urinary incontinence. It's just an alternative. You do not need to use mesh. And the reason I mentioned it, it's a very skilled surgery, but right here in Findlay at Blanchard Valley Hospital, we're probably doing more of those surgeries than many hospitals in all of the state. So it's a lot of good things happening in the surgery department, the anesthesiology department, the nurses, both in same day and recovery. They do a really good job here. Yeah. Another mention, Dr. Adam Walter, he is a gynecologist / oncologist coming from Toledo who can help those women who have been diagnosed with a female cancer and need to have a pelvic surgery, or maybe it's not a cancer, but other pathology that we would like his expertise on. And he's phenomenal, wonderful. And again, something that can happen right here in Findlay in the surgery department, which is great.
So we should probably explain that he normally works out of Toledo, but we've developed a relationship with him, and he's able to come here and help see some patients and do some of the surgeries here. So patients are able to stay local.
Yeah. He usually, and he comes on Fridays. So
awesome.
But that's kind of, I think, what wraps up our, that's a good overview anyways of OBGYN.
We'll take questions.
So.
What do you got?
So Jen, have we had any come in to start with? I have several here, but let's see what you've got.
Yes, we have one that has come in from Madison. What can expecting women expect when they go in to give birth at Blanchard Valley? Who will be in the room during delivery? I guess specifically related to COVID.
So maybe
Okay.
Allison, let's just walk through the process.
Okay. So here at Blanchard Valley, throughout the entire pandemic, we felt very strongly that regardless of the visitor policy, that our laboring patients really needed at least one support person. So thankfully, we've been granted to have that one support person. Unfortunately, it still is just one support person, but it's one person the whole time. So usually it's dad or whomever you have. They are able to come and go reasonably. He's not a prisoner on labor and delivery. So if he wants to go grab something else to eat or go let the dogs out, he doesn't have to leave. We are also providing him meals, just like the patient meals through his and her entire hospital stay. When it comes time to delivery, we have at least one nurse in the room. The provider is in the room. Sometimes we have a patient care tech too, if we just need a little extra support, and then whoever the support person is. Occasionally we'll call in the special care nursery staff or even the pediatrician for delivery for certain high-risk circumstances. In terms of mask wearing, the question I get, do I have to wear a mask while I push? No, I will wear my mask. You don't have to wear yours. But just like everyone else, you got to mask up when you come into the hospital. And if you'll be out walking the hallways, we ask that you wear one.
Yeah. And that policy, I think the biggest thing during the COVID is we want to keep we want to do it for their safety and their health. And that's kind of
limit exposure to other people,
exposure.
Especially during this time with a little newborn. Yeah. Okay.
We had a question beforehand. Lucy from Bluffton asked along the same lines, are newborns kept in their mother's room at all times, or is there a nursery for them to be cared for while the mother heals, or if the mother were tired or whatever?
So we encourage rooming in babies with moms as much as possible to help with bonding, both in Findlay and in Bluffton. the baby usually only has to leave the room for newborn testing or a procedure, or unless the baby is admitted to the special care nursery for other treatments. But we try to keep moms and babies together. There are some circumstances where mom just needs a little bit more rest, and she can usually work something out with the nurse. But there's not, the old 1980s movies with like the window and everyone staring at the babies, wondering if they got switched at birth. That's most of it stays in room now.
Yeah.
Along that same line, we also really encourage kangaroo care, that skin to skin for that first hour after birth. We try to delay the first bath to try to help promote breastfeeding. We try to do some delayed cord clamping, and we have lactation consultants too available at most hours for breastfeeding help.
Right.
So talking about breastfeeding, is there education prior to coming into the hospital? Sarah, is that something you do, or how is that coordinated? You said we recommend that now. That's been a little change, what might have happened over the years.
So I think a lot of times it's finding out during their antepartum care that breastfeeding is going to be something that's important to them, and then getting them hooked in with a lactation consultant or prior to delivery, or certainly at the time of delivery in the hospital.
Most of the education comes as hands-on after the baby's born, because that's really going to be the most effective. And that's why the lactation consultants are available at Findlay and Bluffton, and they work really long hours.
Yeah.
And if they're not there at 3 o'clock in the morning, there's always a nurse available who has probably breastfed her children too and can help you with it.
Absolutely. I was just going to that reference to that. So,
Jen, do you have any other questions right now?
I guess specifically there was a comment that came in that said, are doulas now permitted as well?
So a laboring patient can choose one support person, and it can be a doula. We support that, but it cannot be a support person plus a doula right now, secondary to COVID.
So you want to expand on what a doula is for somebody that's a little uneducated about that?
So a doula is someone who their aim is to support a laboring patient during labor, whether it's like focusing on breathing, helping with some alternative techniques for labor pain control, really, and to try to help them keep moving so that their labor.
Yeah, they usually kind of help the patient develop a birth plan. And so this birth plan from start to finish of what they're trying to, what they want to accomplish and the kind of experience they want to have, the doula can help them.
And that relationship would have been established prior to coming into the hospital.
Yeah.
Okay.
So
I have a question here from Jennifer in Findlay. If I would like a midwife to deliver my baby, can I deliver at Blanchard Valley Hospital in Findlay, or do I need to go to Bluffton, vice versa?
Yes.
What's the story about midwives?
Yep. So we have several midwives, Missy and Laura. They are amazing. They have privileges to deliver at both Findlay and Bluffton. So that would definitely be an option. That's the short answer. The longer answer is it probably also depends on what's going on during your pregnancy. That may determine, where you deliver.
And so what is a midwife? Where do midwives come from? What kind of training do they have? I asked Sarah about that. And how do they work with physicians, with obstetricians?
So nurse midwife basically is a nurse that went on with extra training to specifically deliver or be there through the labor and delivering process. So that's their specialty. That's kind of what they're there for.
The state of, so each state has a different set of rules and regulations about what they consider a midwife versus a lay midwife. And here in the state of Ohio, they do have to be a nurse, and they do have to go on to have some advanced training, not just educational training, but hands-on experience. Most of them have been labor and delivery nurses at one point in their life, and that's been really helpful. This is different than a lay midwife, who is just someone who maybe has had birth experiences and would like to help people, but is not necessarily a nurse or has not gone through formal training.
Have a degree.
And you might comment, Dr. Westcott, you were head of the Department of Obstetrics. That's part of what we do in credentialing.
Yes.
Those individuals have privileges that we look at on a every two-year basis, make sure that they're competent, keeping up with things just like we would with
Yeah,
Sarah or with anyone else,
Well,
and they're part of the team.
Yeah,
absolutely.
any other
And-
part
and-
of medical staff. Yeah.
And to mention, midwives like physician assistant and nurse practitioner, they're also trained in GYN services too.
Yeah.
So I guess, that sometimes gets overlooked. They're able to do the in-office evaluations and help with GYN problems as well.
Yeah.
Great.
So,
We have a question from Jerry in Finley. What is your medical opinion on the rise of the number of C-sections over the years? First, is that true? Maybe talk a little bit about why do we do C-sections and
Yeah.
what is a C-section? Let's just talk about that as a topic.
We could spend an hour on just this one topic.
We don't have that much time.
Okay, so, here at Blanchard Valley, we feel really strongly here, Finley and in Bluffton, we feel very strongly about trying to prevent that first C-section if we can, and really trying to get a good vaginal delivery. Our main goal is healthy moms, healthy babies. And we're not going to put a baby at risk just to try to get a vaginal delivery.
right.
But so some numbers. The national average C-section rate, and it's been pretty stable over the last decade, is about 30%. That's all C-sections. Going back about the last decade here, ours is pretty stable around 28%. So we're a little bit lower than the national average. I think the most important number to look at here is our primary C-section rate. This means someone's first C-section. The national goal is to not exceed 23%. Since I've been here, the data shows that we are consistently 14 to 15% primary C-section rate, which is well below the national average. So we really, the numbers show that we really try to get that good vaginal delivery.
Yeah.
So what happens when you have a C-section? I've got a couple more questions. So
Okay.
what's the procedure?
So someone might have an epidural already because they were in labor. If not, the anesthesia will give them a procedure called a spinal. It's very similar.
Yeah.
And you're kind of numb from here down. You still feel us pushing out the baby. And we do it through a little bikini cut incision. Most of us use stitches, so you don't have to worry about the stapler anymore.
All absorbs. And,
Yeah.
I love C-sections because I actually usually help to assist. And so that's, definitely a fun procedure, a very special one.
It's rewarding when you get a good baby.
Yes, yes.
So
And
mom's awake?
Mom is awake.
Mhm. I tell patients it's so awkward and weird because there's a blue drape and that we are doing surgery on you, but you're not really feeling anything sharp or painful. It's just awkward because you're awake, but we want you to be awake for the birth of your baby.
Yeah.
And it's just such a cool thing.
Typically baby comes out, we try to show mom a quick peek. There's usually someone who's there with the mom, obviously is there. And then once the baby is handed off, cleaned up, swaddled, they usually give that
Back to
baby
mom and
right
dad.
to
Yep.
mom and dad so that they can have some really great pictures. And
Yep.
and
And one of the questions I get is, can I do kangaroo care with a C-section? Answer is yes. Your arms aren't strapped down to anything. You moving yourself, it's not going to mess up anything that I'm doing during the C-section.
Yes.
I think the biggest thing comes to patient comfort, just because you're flat. So some of the larger chested ladies, it gets harder to put one more thing over here when you're laying down. So it's all really about patient comfort and what they want to do. But certainly, mom and dad are there to kind of help hold the baby and get first looks.
How long does it take for the anesthesia to wear off? And do you need to stay in the hospital longer if you've had a C-section?
It takes a few hours for the spinal to wear off. The whole procedure lasts maybe 60 to 90 minutes. It's not super long. Getting the baby out is the quick part. And then it seems like it takes forever to put everything back together. And then it's usually just one additional day more than what a vaginal delivery would be.
So I was trained 50 years ago, once a section, always the section. Is that still true?
Nope. We definitely offer VBACs.
What's a VBAC?
Oh, I'm there. Vaginal birth
birth.
after C-section.
You got it. Yeah.
And we currently offer them at Finley. We're not able to offer VBACs at Bluffton. but we are able to offer them in Findlay, and we encourage it to help keep C-section rates down.
Yeah, we usually just try to make sure that that patient is a good candidate for a VBAC. Obviously, there's some extra risk with having a vaginal birth after already having a C-section. So it's just about making sure that that patient is a good candidate, making sure they're well informed, and consent to it. And if that's what they wish, then we certainly will try to accommodate that.
So before we leave the C-section, I think maybe part of the question was, do you have criteria for when you do a C-section? Timing, problems, et cetera. What's generally the reason that somebody does have a C-section?
Certainly, a lot of factors
Yes.
can warrant a C-section. Obviously, if there's anything emergent where we feel the baby's in distress and the better for the baby to be out than in, and we can't wait for the laboring process, those would require an emergent C-section. But there might be other reasons to do C-section.
If a baby is breech
Mhm.
or sideways, we're
Yeah,
not going to deliver arm first. It just doesn't happen well that way.
yeah,
There's other issues, like if a mom has eclampsia, which is where they have a seizure with preeclampsia, and they are not in labor and nowhere near having a vaginal birth, that is an emergent condition that we would definitely want to get the baby out if the baby's in
yeah.
distress.
So maybe the mom's been laboring for a long time and just isn't making progress, and we feel that the baby's in some sort of distress, and it just doesn't seem to be happening vaginally. That may be a reason to do a C-section.
It's hard to put a law on,
Yeah.
okay, you've been exactly 6 centimeters for exactly this amount of time, because every patient is different, and it's not fair to lock everyone in there. But there's standards and there's general rules, but we really try hard. We will try everything to try to get a good vaginal delivery without risking the baby.
Exactly. At the end of the day, you want a healthy baby. And so if C-section is the safer way to do that, then I think that will be what the decision is. And hopefully we do a good job communicating that to the patient and making sure the patient is on board.
Patients have a say in that.
Mhm.
Mhm.
I know you've done a lot of work in your department about the infant mortality, and I think that has something to do with when a C-section's done. The longer the baby is inter utero, the better off. Do you want to make any comments about that, just about what you're trying to do to, again, infant mortality is a big thing in Ohio. I think we were one of in the lower decile. And so there's been a lot of work by our department and across Ohio to take care of that. And I think C-sections were one that you keep very close track of when somebody's electively scheduled, how far along they are, and et cetera.
So in order to prevent that first C-section and increase risk to mom and baby, we are able to electively induce patients after 39 weeks, but we have a discussion with the patient ahead of time about what's happening with your cervix. Is this appropriate? What other risk factors do we have? And so that's something that happens before they even show up to labor and delivery. Specifically, though, we work very closely with the pediatric hospitalist in terms of antibiotics during labor, if it's appropriate, having the pediatrician attend the delivery if needed, working closely with the special care nurse.
I'm new to the area. How do I find out who is accepting OBGYN patients? In addition, does your practice have early morning hours and late hours? I know you just touched on that, but maybe.
Specific question. Great question. Thank you.
So our phone number is, I got to look at my cheat sheet because I don't ever call it.
Yeah, the worst thing to have is the wrong phone number.
I don't want to say this incorrectly. 1-844, the letters OBGYN, the number 4, letter U. 1-844 OBGYN for you. And that will get you in touch with, it will connect to any of our office locations. We are pretty much all taking new patients. They will get you in with a provider that you prefer if you need something specific. If you prefer a midwife or someone who does surgery.
Absolutely.
And hours?
And hours, we do have some locations who offer 7 a.m. to 7 p.m.
Yep. So different providers at different times.
Another question, Jen, or that?
Yes, we actually have one more question. I'm sorry. Do you help with infertility?
Let's just talk about infertility in
yeah.
general.
I'm going to let Sarah take this one. You do a lot of it.
Yeah. So infertility, the diagnosis of infertility is typically if you've been trying to conceive for over 12 months, so 1 full year without success. The average couple will take about 4 months to conceive. So if it's not typically a problem unless you've gone over that full year mark. But certainly if you have, that's something that we can help you with as well. We will do a lot of the baseline lab work to assure there's no metabolic or other problem contributing to the fertility issue. Certain imaging may need ordered. If we do find, okay, you could be helped, we certainly can prescribe ovulation induction medications, perform the follicle scans.
So what we mean by that is like ultrasounds.
Yep.
So we'll generally evaluate things with ultrasounds. We can do blood tests.
Yep.
There's physical exam.
Yep.
We can check the male sperm.
Male sperm count.
That's a big one.
Yep.
And we're also able to do HSGs at the hospital.
Which is
That is a very
salpingogram is
Yep.
what that stands for.
it's a really special procedure that we do in the x-ray room.
Yep.
It's kind of weird, but we basically shoot some dye in like a pap test to see if the tubes are open and to make sure that the uterus looks normal on the inside.
Yep. And we will go as far as is performing what we call an IUI, which is an intrauterine insemination. So that's an in-office procedure. If we find, okay, maybe that sperm
Sperm count's
needs
a
a
little
little
low.
help to get to where it's going, we will, wait until a woman is at her fertile time, get that specimen and do the insemination in the office if that can help a couple. So we certainly will. We do not do IVF or in vitro fertilization. That is something more accomplished by a reproductive endocrinologist, but we certainly can help out. And
We pretty much do everything else before we get to that point.
Mhm.
And if a patient chooses to undergo
Yeah.
in vitro fertilization to achieve pregnancy, we take our patients back as soon as we know that they get pregnant and they
Yeah.
they have a little baby in there.
And a lot of times we can handle, I guess there may be a case if it's a really significant case or we do some baseline labs and we think they might be better suited with a reproductive endocrinologist, we'll get you there, but we'll certainly try to help navigate that. We work with reproductive endocrinologists and can handle the referral if we need to.
Yep.
We had a
So-
question about this, about lifestyle modifications related. It was specifically asked about about exercise, a healthy diet, helping to increase the chance of pregnancy. Are there things that you can do, or you talk to people about alcohol, smoking, tobacco,
You got it.
any kind of things that you advise people? Is that going to improve their chances of getting pregnant?
Absolutely. Lifestyle modification is a good start. Weight loss, well, if you are underweight to start, obviously we wouldn't want you losing weight. That isn't going to help. But specifically, I know with PCOS patients, I know they've definitely done studies. If you are overweight and if you lose just 5 to 10%
Yeah.
of body weight,
Yeah.
the chance of that alone helping you to ovulate is like 50 to 100% effective with just weight loss alone. So I think, starting with weight loss with that goal of trying to lose 5 to 10%, if you're struggling, is a great thing to try initially. And, that will help. And then as, like Dr. Kose mentioned, other lifestyle modifications, smoking cessation, decreasing if you're doing a large amount of caffeine, that's not helpful. So decreasing caffeine amount and decreasing alcohol consumption, all are good things to help fertility.
We should probably put out there prenatal vitamins.
Yeah, good point.
Prenatal vitamins do not make you pregnant. I have some patients who don't want to take them. It does not make you pregnant. However, if you are attempting and you are trying, studies show that if you take your prenatal vitamin, which has a little bit of extra folic acid and some DHA, that will help prevent birth defects like spina bifida, and it may even decrease the chances of autism.
So
Thank you. Switching gears a little bit, we had a question, the 2020, due to COVID-19, how does my experience with labor and delivery look different? I think you touched on that a little bit. Big deal. We doing things a lot differently?
So we just limit the amount of people that are allowed in the room. So there's just one support person with mom. And even after the baby's born, we still only allow that one support person. So there's not a lot of other visitors on labor and delivery Again, you have to wear a mask when you come into the hospital and if you're out in the hallways. But if you're in your hospital room, you don't need to wear a mask, and you don't need to wear a mask while you push.
Which I know is tough, and sometimes it's certainly been an adjustment with the one visitor. But again, we're trying to do it in the for safety, and and hopefully it's short-lived and we'll go back to normal. But right now, with things the way they are in COVID, I think it makes the most sense.
So what if someone is pregnant, of avoiding other people while they're pregnant? Are you worried about intrautero infections more so than what normally people would do? What's your advice to someone who's pregnant about COVID?
So the data is all over the place, and there's little pockets of studies that come out almost every day with very conflicting results. But what we can see so far is any pregnant woman, because of the slightly suppressed immune system due to pregnancy, is at risk of any infection more than the general population.
We knew that already.
Yeah, whether that was flu, cold, COVID, pneumonia, anything. It shows that the OB patients don't seem to have a worse disease.
Right.
Like they don't do any worse than anybody else just because they're pregnant. There might be a chance of intraplacental transmission, which means if mom gets sick while baby is still inside, there may be a small chance that the baby could get COVID while it is still inside, but it doesn't appear to be very likely.
Yeah.
And it doesn't appear to have a big harmful effect on the infant. This is what we know so far.
Yeah.
Again, there's little pockets of studies. You can prove your point one way or the other with about 5 patients, but.
So, I mean, the key is for our pregnant patients, you're in an immunocompromised state. That we know already. That's the minute you become pregnant, that's what happens. So just make sure you're washing your hands, you're wearing masks, you're avoiding contact with people who are sick, doing those things. Just do what you can to boost your immunity, get enough sleep at night, well-balanced diet, all those things that we know can help your immunity. That's what you should be doing.
You're still allowed to go to work. Like you're still allowed to be a human being. You can still take care of your kids and go get groceries, but try to do it as safely as you can. And even if others aren't socially distancing, just try to do the best you can.
Sarah, you mentioned endometriosis. We have a question. Are your providers still finding many people who suffer from endometriosis? Can you tell us a little bit about what it is, and can you do anything about it?
Yeah, good question. Yes, absolutely. Endometriosis is something that we see. I was just reading an article that talked about 70 to 80% of female pelvic pain is likely associated with endometriosis. So it's definitely out there, prevalent. Endometriosis is a condition where endometrial implants can grow anywhere inside the pelvis. So it can cause things such as irregular periods, pain with intercourse,
Infertility.
fertility issues for sure. It can grow anywhere, so it can even cause bladder problems, bowel problems, and there's many different stages of it. So the other interesting or almost sad statistic that was in the same article was that in the USA, it takes an average of 10 years before a woman can potentially get the diagnosis of endometriosis. And so obviously, if you're having those symptoms, that's kind of sad. I would hope to think that's not in our practice. So hopefully you're getting the care if you're having those symptoms, get in, be evaluated so that we can.
And that's why we have the pelvic pain clinic too, just because there's a specific subset of ultrasounds and potentially surgeries that we do to look for that. So
yeah.
Jen, what's coming in over the airwaves?
Sure, there's a question related to menopause. I am 37 years old. Am I too young for menopause? And what are some of the symptoms I should be looking out for?
So premature menopause is anything less than the age of 35, but even before 40, it's not normally common.
I would agree. So I think if you're, we can evaluate for it. Typically looking at some hormonal labs, we could kind of decide if that's something that is a problem. Symptoms, if you're going through menopause, can include what we call vasomotor symptoms, which essentially is when you are having the lack of estrogen and progesterone, you can have things like
Hot flashes, night sweats. Here's the thing with hot flashes. It's kind of like labor contractions. So you kind of get hot one day, you're like, that's it. I had a hot flash. I know that that's what it is. And then you have a real hot flash, and it is like hot lava is just pouring out of your face. You are sweaty. You cannot tear off all your clothes fast enough. Then you have a real hot flash, like, oh, everything else I felt for the last 10 years, that was not a real hot flash. This is a real one.
I tend to think if I ask a patient, are you having hot flashes? And they say, well, I don't know. No, you're probably
you
not.
know when you have a real one. It's just like when you have that baby for the first time, you're like, I had a lot of false alarms, but this is a real labor contraction.
For sure.
So it's that same kind of thing. Average age is like 50, 51.
Mhm.
You two aren't exaggerating.
Not us. But yeah, I think, in seriousness though, if you are having symptoms like that, especially if they're affecting your quality of life, important to get evaluated. So again, trouble sleeping, mood changes, hot flashes, night sweats, trouble focusing or concentrating. Those are all things that some women will complain
Irregular
of.
periods
Yeah.
and missing periods.
Mhm. Yeah, that's obviously a big one, is when your periods.
And it may not be premature menopause. There's some other OBGYN concerns that can mimic some of those symptoms. So I would definitely get it checked out.
Well, you brought up estrogen. We have a question about, the question's asked, what types of issues do your provider see related to increased amounts of estrogen? Let's just talk about estrogen in general. Again, over my 50 years, give everyone an estrogen, don't use estrogen, give estrogen. Where are we now and how are we treating? I guess you could start with the menopausal symptoms, but there's other reasons you might treat bones, heart.
Right.
Where are we with all those things?
So, I mean, estrogen, we could talk about that for a whole hour, but it's kind of gone in waves, right? Do we use it? Do we not use it? That sort of thing. But first, to start your question, what kind of things does estrogen cause? So I guess if you had an excess of estrogen, things that you would notice might be breast tenderness, maybe headaches or hormonal migraines,
Irregular
periods. I guess if you had too much estrogen in relationship to your progesterone in your menopausal, things that you might worry about would be like an endometrial hyperplasia or a precancer. So estrogen,
PCOS tends to have more estrogen, less progesterone. So that's another diagnosis we see.
Yep. So, but yeah, I mean, as far as, in a perfect world, women will have a balanced amount of estrogen to their progesterone at certain times in the cycle, which will help create a normal menstrual flow and also help with a lot of the symptoms that make people feel well. And when those hormones aren't balanced, that's when women might have symptoms or problems. So I think to make it not too long or short, I think the key with hormone or that sort of thing, and maybe you would agree, is that it's got to be an individualized decision, care plan with that person, benefit versus risk ratio based on age, and other things that might be, in their health history as to whether or not it's a good idea or not. But yeah, there are many times where using hormone therapy, we can use it safely and effectively for the right candidate.
It helps with hot flashes. It helps with that menopausal transition. I tell my patients, hormones are not life-saving. It may seem like you're going to die from hot flashes. Maybe someone else will die from your hot flashes, but it's not really life-saving. It's not like insulin for a diabetic.
Right.
But if it's really impairing your life, then maybe hormonal treatment is an option for you.
Yeah.
In terms of other things to use it for, do we use it for bones? It does have the side effect of helping your bones. So in menopause, if you're on that, it does help decrease that menopausal bone loss. Although due to other risk factors, we're not supposed to use it solely for bone health, although it does help.
It's kind of, like I said, well, maybe I'm going a little too far, but way back when I was in school, that's all we heard about was hormones were great. Basically, anyone who even started into perimenopause or was close to menopause, put them on a hormone and leave them on it for life. And 2002 was the big Women's Health Initiative study. And that study, well, I won't go into it, but essentially it just made everyone scared of hormones. Now, I think we're learning a lot from that study.
If you need it, you start earlier in menopause.
Exactly.
If you're already 75 and you already have had bypass surgery, do not start taking hormones. But in terms, go ahead.
Timing hypothesis, using it in that window, maybe 45 to 60 would be
Fair's
ideal.
better. Yeah.
Okay,
It is
you.
not meant to prevent heart disease also.
got it. Jen?
Yes, we have a question. For young women's first visit, does a parent or guardian need to accompany them in their room during the visit?
It depends on the age. So if you are under the age of 18 and you are not emancipated, generally a parent or a guardian will have to sign a consent
Sign a
for
form.
treatment, which just means we are able to treat you.
Yes.
It's up to the patient and their support person whether they want to be in the visit or whether they don't want to be in the visit. So that can be individualized.
Absolutely.
We have a question from Mary and Finley. Is a tubal ligation able to be reversed once completed and healed?
Yeah, so tubal reversal is something that can be accomplished. A lot of times that's going to be dependent on certain factors like how long ago the tubal ligation was done, which type of tubal ligation was done. Did they take your entire tube? How much of the tube did they take? Did they burn it? Did they clip it? You know, these things are going to be important as to whether or not they can put it back together. So I think the overall national statistic is kind of big as far as like there's a 20 to 75% chance that a tubal reversal will result in a successful pregnancy, which is a pretty large gap, but I think it depends on those other factors. So I know we have done tubal reversals in Blanchard Valley Hospital in the past.
And the thing I would like to touch on with that is there was a study that came out a few years ago that said if you're going to have your tubes tied, if the doctor takes out your tubes completely, it decreases your chance of ovarian cancer lifetime. So there's been a big push that if you're done with kids and you don't need those tubes for anything, take them out. It decreases your risk of cancer. So more people have been doing that. If there's no tube, there's nothing left to be put
There's
back
no
together.
reversal.
Can't
Yeah.
reverse it.
Yeah.
Right.
So
let's finish up. We've got a few minutes just talking about high risk, and one of those is diabetes. The question that we have here is what types of treatment should I expect if I have been diagnosed with gestational diabetes, but maybe just expand that to diabetes. And maybe the place to start would, what's high risk mean? I know we've talked about that. Is it high risk to the mother? Is it high risk to the baby? How do you kind of segment them? And then let's talk a little bit about diabetes.
So most of our patients will have even a diagnosis code on their chart that says, you know, high risk pregnancy. Even if there's something like anemia or doesn't seem like it's really high risk, if it's anything outside of 100% perfectly normal, we can put that diagnosis code on there, and insurance is more likely to pay for more things for you. However, there's other conditions that truly mean high risk, and it is high risk to both mom and baby since they're a coexisting pair. I'll first touch on gestational diabetes because I think that's the easiest one to start with. Once it's diagnosed in the third trimester, usually around 28 weeks, we help the moms by giving some dietary education, some diet changes, and we have mom check her blood sugar a few times a day and just make a record of it. We follow closely with a dietitian, we check blood sugar logs, and we make sure that just with diet modification that moms are successful in having normal blood sugars to prevent risks to the baby. Most women do not need to take medications for gestational diabetes. There's some ladies who end up taking a pill, and then we always talk about insulin as a last resort. I would say it's less than a quarter of our patients with diabetes who even ever end up on insulin.
Yeah, but you hope that by following an appropriate diet and making sure that you are doing a food log and paying attention to the sugar that you're eating, we can keep the sugar levels down, which will help the pregnancy. Because what happens is if you're getting too much sugar, or if you're gestational diabetic, essentially what's happening is that baby is getting all that extra sugar too. So the baby's going to grow faster, but also the baby will have all the complications that one might have if they had regular diabetes. So the baby is going to have any of the micro or macrovascular complications that you would have in pregnancy.
Yes, specifically, we worry about lung development in those babies. Bigger does not mean better. We've had some 10-pound babies from diabetics, and it doesn't mean that the lungs are developed because of the excess sugar.
And then let's say that baby has been the mom has been diabetic and it's been uncontrolled. So those blood sugar levels have been very high during the entire pregnancy. And so that baby's kind of used to that blood sugar level. And then the baby's delivered eventually, or what could happen then is now the baby's only getting maybe a little few ounces of breast milk or formula. All of a sudden the blood sugars are going to drop and that baby could have what we call hypoglycemia, which could be very dangerous to the baby. So it's something that we worry about there. Or again, if the baby has grown larger because of the extra sugar, the risk to the delivery itself, shoulder dystocia potentially. So it's certainly something that if you have gestational diabetes, it's worth, following the rule, trying to follow the diet, make sure you're getting the medication, and we'll kind of work with you to make sure that you're on the right path and on the right medication.
We have a question here about Dr. Doty. I'll take that one. Dr. Doty relinquished her privileges here at the hospital, and then she is no longer delivering. I would encourage you to contact her office if you have any questions. The last topic before we stop, we're all really proud around here of what your department's done for one of the segments of our society that doesn't always get good care. And so maybe both of you talk a little bit about the MOMS program, about what that is, who it affects, and especially as we try to take care of these young babies.
Yeah, so the MOMS project stands for Maternal Opiate Medical Support. And this specifically was developed to help our ladies who are struggling with an opiate addiction and who are pregnant. We want to make sure that they get really good care, that we have some healthy moms and some healthy babies. It is led by nurse navigator Jennifer Loera, and we, during OB care, sometimes realize that someone is using, maybe they are already in a treatment program, maybe they are using something from the street, whatever it is. We try to get them hooked up. If you want care and you want to detox from that and start medical support, we have avenues for that. We don't actually prescribe maintenance therapy in our office as an OBGYN, but we do provide the obstetric care for that. We follow things really closely.
Absolutely.
And a lot of it is also social and that kind of support.
Providing them with the resources they might need to help them through that, because that's our goal. Helping them essentially is so important for them. It's very important, obviously, for that baby who's also our patient. So the MOMS program has been wonderful in helping that.
We're able to keep more moms and babies together with that program, and that's awesome.
Yep.
Well, ladies, we're about out of time. It went very fast. Thank you very much for being here. I think you can see to our listeners, this is Caring for a Lifetime, our mission. We got some really extraordinary people that were here, the whole department, in addition to, I think we're giving really exceptional care. So with that, reminder, please turn in your survey. Let us know what you think. If there's topics you'd like us to discuss, we appreciate it.